Good morning, everyone. Welcome to this session. This is Do the Right Thing, addressing stigma and discrimination among key populations in healthcare settings. I'm Chris Byer. I'm going to co-chair the session this morning with my colleague, Manuel Gonzalez, who we would like to thank for just serving a wonderful term as co-chair of the IAS's Industry Liaison Forum and really being an inspiring leader. This initiative grew out actually of an activity within the International AIDS Society in our Industry Liaison Forum, a campaign that we call Me and My Healthcare Provider. And the idea was to try and bring together healthcare providers working on reducing HIV-related stigma and key populations-related stigma, because those two things are not always the same, although obviously there's a lot of interdigitation, a lot of overlap in stigma in healthcare settings, along with their clients. And to bring those stories forward of people, particularly in settings that are challenging for key populations, providing quality health care and really overcoming stigma where it matters most, which is in people's lives and in their clinical care. So we're really delighted to have a wonderful panel of folks and a number of providers who have been leaders in this area. And to kick us off, really our first speaker this morning is somebody couldn't actually pick a better person to talk about stigma and key populations in healthcare settings than Cameron Wolfe, known to many people here, a leader in FHI 360. And Cameron, of course, is at USAID. He's headed up now. You direct the Key Pops program at USAID, is that right?
Technical advisor.
Technical advisor, okay. But also well known to us because, of course, he did his PhD at Johns Hopkins in our department. Know you're kind of getting on there when people you've mentored as students are leaders in the field. but I'm very honored to be introducing him. And Cameron, please, you're going to speak to us today about access to stigma-free healthcare settings for key populations, challenges, and opportunities.
So thanks so much, and really good morning, good afternoon. It's all kind of running together. It's been an amazing 3 days. I stand on the backs of giants. It's been a wonderful opportunity to be here with all of you, and I'm really honored to be here with the providers who are here, who have done such extraordinary work. My job, which is kind of a thankless task, is to try and set the stage on some of the issues around stigma and discrimination with healthcare settings in 8 minutes. It's a big topic, but I'm going to give you a couple of highlights because obviously I can't get into all of the nitty-gritty, and I think the real highlight will be hearing from the providers about their secrets to success, which is really about building trust with the community members. So I guess I want to start by saying that I've been really, again, standing on the backs of giants, working in the last 3 years, particularly with Ambassador Birx, who in this quote said, we know that if any one of our populations is left behind, if any one of us is left behind, all of us are left behind, and we won't be able to control the epidemic. So starting with the latest statistics, we know we're being left behind for key populations. So thinking about the key populations here, men who have sex with men, transgender people, sex workers, and people who inject drugs, clearly we are not doing enough. And clearly the issues that are going to be outlined here about working with people's trust and building back the bridge between the community and the provider is really what it's going to take. So the latest statistics, as you've probably seen, 44% attributable to key populations, 25% in sub-Saharan Africa, 80% outside. And we have advancements, both in the monitoring and our estimations. So those estimations that we just presented were things we never had in the past. It was just an unstated figure about key populations. And so moving forward with our measurement and our ability to monitor and estimate the key populations that are in epidemics and then the specific service delivery across the cascade, both in terms of the health interventions as well as the structural interventions that are listed here in the blue that WHO gave us in 2014 and then updated more recently last year in 2016 with consolidated guidelines. You've all seen these cascades, but I think the key that is different about this one from linkages, which is our PEPFAR and USAID Premier Key Population Program, is that the issues of stigma and discrimination and human rights and gender equity are really cross-cutting along every step of the cascade, as well as the community engagement necessary to build the trust. We know that it is stigma that is the barrier between each of these steps, that when one goes to a service and they're treated badly, they don't come back. They hide, they disappear, they move away, they change their name. They're lost, and they're lost because of that hostility. They're lost without the trust that's necessary to move them across the cascade. And we also know that key populations are different. They're not unique, that there's intersectionality between different key populations that overlap their stigma and add to their vulnerability that must be addressed. And we're making advancements then in monitoring these issues. And I think that I'm just going to touch on a few of the things that we've learned in terms of our measurement. The first step is really about tracking access. And at PEPFAR, we've now got key population disaggregated indicators for reach, for testing, and for access to treatment and linkage. And being able to show those those who access each of those steps along the cascade is really the first step towards addressing the inequity that lies between key populations and others. And being able to take that data to the granular level at each of the CBOs and each of the geographic spots is really what makes a program able to be improved. This is from the new GNP Plus director, Laurel Sprague, again reinforcing the fact that while HIV may be declining and many people are accessing treatment, key populations really still are struggling and left behind. We've known at the PEPFAR level that we have to start first at our own headquarters and starting with our own programs and our country teams. And so what we did is we trained every single country team that did a PEPFAR COP, or country operation plan. So every one of those over a 2-year stretch was trained, and now we're moving into subnational trainings. And it's not just the PEPFAR USG teams, but it's our multilateral stakeholders, our implementing partners, and all of those stakeholders who are necessary to move forward the agenda in a non-discriminating way. We've partnered with UNAIDS to revise the Stigma Index. And the Stigma Index is an amazing tool that's trained hundreds of interviewers, people living with HIV who live the process. They lead the process, they move the agenda and the advocacy with evidence, and have reached over 100,000 people living with HIV in 90 countries. But what's been revised is the actual response and the ability to respond to the response. So we have care and treatment now with Treat All. We have PrEP. We have new dynamics that need to be tracked, and we have a systematic way now to look at key populations. And here's an example. This is brand new data from the revised PLHIV index from Senegal and Uganda, looking at MSM and sex workers. And you can see that indicators here around the fear around and perception of fear around healthcare services is still quite pervasive, and it gives us somewhere to track as we move forward with our interventions. We also know that we have to be monitoring at the higher level, above site, as we say in PEPFAR. This is just a slide from Ghana, not so clear, but what it is it's a monitoring system that tracks complaints and redress for those who have experienced stigma. They can text in or website in or call a hotline, and there's a whole processing system then that works across allies to ensure that at each stage of the complaint that they're addressing and dealing with ombudsmen and all of those in the legal system. And those complaints come from issues that pertain around pervasive violence, stigma, and discrimination. This is something Linkages has championed to pull together partners that are working in all different ways, including building upon the work that HIV/AIDS Alliance has done with the Elton John Foundation funding. This is work that builds the best practices, the tools, the measurement across different partners, and moves forward with new opportunities to learn from each other. These are some of the partners and international networks of key populations and members that are already participating in this, we call it TAG, the Thematic Advisory Group for Violence, Stigma, and Discrimination. There was great work presented here today. There's work that's been presented earlier on Sunday in the session for Key Population Implementation Science. This is just showing how the frameworks are addressing at multiple levels and our ability to track. I'm not going to go into the specific concept here, but the ability to track and monitor is leading us to understand these indicators across countries. And we have tools now. In the past, when I started work at USAID, there really weren't indicators or tools, and now the MERG, the UNAIDS indicators have all been updated, the tools are there, and we need to couple the tools with continuous ongoing training and program improvement. And this is some work from the Laura Nyblade and the Health Policy Project that continues to move forward with studies and with interventions. And at Linkages, we're doing what we call SMS squared. And this is a system for continuous quality monitoring using SMS and text phones and smartphones and using the new technology that exists and that people have access to between outreach workers, the key population beneficiaries and providers, and providing continuous feedback like a Yelp system or crowdsourcing where people can use that for pinpointing problems, issues of satisfaction, and ability to respond. And we have other tools that have been developed, implementation tools for sex workers, for MSM, and for trans people. And then drug users is coming out probably in the next month or so. It's out, okay, it's out. And so we're adding to our arsenal of our tools. But the issue is that if we look at our UNAIDS report, the countries, they say they don't even have these tools in many cases. You can see that a country that has any training program on the left, and then countries that have done any training on human rights for people living with HIV and key population in the past 2 years is less than 50%. In almost every region that's reporting in the world. So clearly, we have the tools, we have the advancements in measurement, we have the indicators, we have the way forward, we must do better. PEPFAR has a stigma and discrimination task force. There was an expert consultation that was held November 2nd and 3rd, and this was a compilation of pulling together the best practices following on the White House stigma consultation and other expert consultations that are leading forward our way for program improvement. And I think that the point now is really to take what we've learned and move. So in summary, there's been incredible advances, but it's time to scale. We have a better feedback between key populations and care providers, and we know that this leads to accountability, and this is a plank for everything that we do. And we know that full community engagement across the cascade, across every aspect of our programming, leads to better improvement. We've seen that here in our posters, in our sessions, but now we have to do it. And one of the keys for doing that are the allies and the champions that are here in this room. And so I think that they are the ones who are making the impossible possible, and the time is now. Thank you.
Well, thanks so much, Cam, and I think we heard you loud and clear. It's time to take these critical interventions to scale, and you've set us up just beautifully. Our next speaker is known to many in the room. Kate Thompson is head of the Community Rights and Gender Department at the Global Fund to fight AIDS, TB, and malaria. She's been at this for more than 30 years, working with civil society and communities. She was a founder of one of the first positive networks in the UK, Positively Women. 1992, she took on the leadership of the International Community of Women Living with HIV. She then moved on to Geneva. She had a long career at UNAIDS, and of course she has now founded and set up the CRG department at the Global Fund. So Kate, please.
Thank you, and it's a real pleasure to be in this room with so many champions for key populations, and thanks to Cameron for really setting the scene. So I'm just going to, I think I have 4 overall slides to go through here. And first, a little bit of background and context. Cameron's given a lot already, so I won't dwell too long on this. But just in relation to the Global Fund, it's evidence that human rights-related barriers and stigma in terms of barriers to services really impact negatively on our grants. You know, they reduce uptake and retention in services by key populations. And we know that the denial of HIV and health services for key populations and the stigma and discrimination associated with HIV testing and care, the institutional discrimination that people face, all contribute to increased HIV risk and undermine effective HIV responses for key populations that we're working with. From the Global Fund perspective, in the last funding period, we saw a lack of funding for stigma reduction programs. You know, countries weren't asking for this, and also for programs more broadly that address human rights barriers and increase access to justice. So very little. We did see quite often in the concept notes that we received from countries that human rights barriers to programs were articulated, but then there was little funding attached in terms of what actually got funded or what was requested. So really very little supported in terms of stigma reduction. And what does exist now, so to date, has been at very small scale, and then also very hard to monitor and evaluate because of the small scale. Also, programs to reduce human rights-related barriers and gender-related barriers to TB and malaria services in previous grants have not been clearly defined, despite the recognition that there's a real vulnerabilities of key populations in the context of TB, such as people in prisons, internally displaced persons and migrants and so on. And also just recognizing that we're never going to end malaria unless we succeed in reaching those who are being left behind. So it's not just about HIV. But our current strategy really puts a strong emphasis on scaling up evidence-based and comprehensive programs for key and vulnerable populations in all contexts, while supporting also their meaningful engagement throughout our processes. And it also emphasizes the need to do a lot more than in the past to ensure much greater investment in programs to reduce human rights related barriers to access for everyone. Just to support our strategy implementation, in particular, I want to focus on the work we're doing to scale up programs that do reduce human rights-related barriers to services. So this includes an intensive effort in 20 countries. So in these countries, there are currently baseline assessments taking place that assess not only the extent to which human rights-related barriers exist, but how it also looks at how they can be comprehensively addressed and like what it would cost to do that. And then based on those assessments, then plans will be drawn up, country plans with stakeholders in countries that won't just be about Global Fund funding, but getting other donors to fund. And then this process will be evaluated in 2022 to see like what what difference it has made and how much we have been able to scale up. We're also increasing investments across the portfolio in programs to reduce human rights related barriers, and the target is to increase at least fourfold. We also now have new technical briefs. We've worked very hard with key population networks to develop new briefs on HIV and gender and human rights, as well as separate ones on malaria and TB and human rights and gender-related barriers, as well as looking at human rights within the context of challenging operating environments. So stigma and discrimination reduction is, in healthcare settings is part of what we call the 7 key programs to address stigma and discrimination and increase access to justice, which is actually we're taking this guidance from our from our UN partners, from UNAIDS. And so these programs that we're funding really, and that need to be scaled up, really, to be most effective, need to be delivered in combination so as to support each other and thereby maximise the results. And we're clear that funding needs to be flexible and allow for the building of strong community and health systems by educating and empowering affected populations, as well as healthcare workers and law enforcement officers around rights related to HIV. And just to give you an example, some programs we're funding will include interventions that capacitate healthcare workers on human rights and medical ethics related to HIV and enhance their accountability, for instance, through community monitoring. By providing patients' rights and human rights literacy to key populations to really engage in that monitoring the quality of the services they're receiving. Providing community and peer-based legal services for those discriminated against, and then implementing various community-led and data collection tools to measure HIV-related stigma and discrimination. Cameron talked about the stigma index, also adapting the stigma index to include key populations living with HIV. The Global Fund expects countries applying for funding to develop a comprehensive programme for key populations based on the recommendations in the 2016 WHO Key Populations Consolidated Guidelines that Cameron talked about, but also very much where we're trying to build awareness around the principles and approaches articulated in the implementation tools that he also talked about, the SWIT, the MISMIT, the Transit and the I Do It. So really building at country level, but also internally, knowledge and sensitivity around these. And so, for instance, sensitization of healthcare workers and others in clinical facilities through training on legal rights, HIV risk, and clinical and psychosocial needs of key populations, and on respectful service delivery, client confidentiality, and so on is really key. How long do I have? 2 minutes. Okay. So, just some innovative programmatic examples here. So I'll go through these very quickly. But partnership with civil society organisations to provide training to healthcare providers to meet the needs of key populations is ongoing in many contexts. But also partnerships with UN partners such as UNDP, for instance, to enhance and develop competency of clinicians and community-based staff to really provide quality care to key populations. And then lastly, partnership with the media to challenge attitudes towards key populations is another regional grant that we're supporting. And then just last but not least, some of the key actions that are really needed. So clearly the need to bring to scale quality, comprehensive programs. And then also we need to implement programs to increase sensitivity and competency of clinicians and others providing care to key populations as part of these comprehensive programs. Partnerships with key populations is absolutely central to everything we're doing in the design and implementation of the program. It's a prerequisite. We can't develop these programs without the meaningful engagement and leadership of key populations. And then also the need for efforts to make facility-based services acceptable and accessible and affordable and equitable through differentiated care, and very importantly, assuring safety and confidentiality, always operating on the principle of do no harm. And then last but not least, ensuring the sustainability of programs, which is not necessarily a given, particularly as countries move towards transition out of donor funding, when there's a lack of political will to actually be funding these programs for these particular communities. So I'll end there, but hopefully you've got a snapshot of some of the things that we're trying to do as a responsible donor.
Thank you, Kate. Our next speaker is the first in our series of providers. Neo Nemetso Manapula is a social worker from Botswana. She's been working with women in nonprofits for a number of years, and as a social worker, she's dedicated to improving the lives of women, young girls, and sex workers. So that's the key population that Neo has been working with. And she advocates for accessible and stigma-free services for sex workers in Botswana. And she is currently doing a master's in social work at the University of Botswana. So we're delighted you were able to get away to be here. And she's also a member of the Community Advisory Board, the CAB, for the Harvard-Botswana Institute Partnership, where, again, her role is advocating for inclusion of key populations in the research agenda. So, Neo.
Thank you. I'm honored to be here. I'll be giving my perspective as a social worker in providing stigma-free services to sex workers in Botswana. A bit of context. There is no clear number of female sex workers in Botswana. However, we have an estimate of 4.153 sex workers in 3 districts out of 26 health districts in Botswana. And when you look at the HIV prevalence among female sex workers in Botswana, it's 3 times the general population HIV prevalence. For female sex workers, their prevalence is 61.9, while the general population, their prevalence is 18.5%. In Botswana, sex work is still criminalized. To do sex work, it's an offense. And this is a challenge and a barrier to sex workers accessing services. Sex workers has highlighted that there's high stigma in Botswana, in terms of them accessing health services, and they prefer to give false names so that they cannot be noticed. What I do as a social worker in Botswana is that also I have a slogan which says, sex workers' health is the nation's health, and I love that slogan. If we don't give sex workers services, then who are we protecting? One, I have accepted sex workers as human beings, as mothers, as sisters, and also I'm also dedicated at helping sex workers without necessarily asking them unnecessary questions that will scare them away. One of the things that I do as a social worker is to provide counseling to female sex workers. And I make sure that I assure them of their confidentiality. And apart from that, I go beyond just giving psychosocial support. I also assess their needs, apart from health, so that I can help them better. They have other needs apart from health in terms of their goals in life, what they want to achieve. And I also offer accompanied referrals to make sure that they get another services that I don't provide, especially legal services. Because, as I said, it is a criminal offense to be a sex worker. But I make sure that I sensitize police officers in terms of issues that affect sex workers and make sure that they also get help. I always encourage my co-workers to treat sex workers right, so that they cannot go into hiding, so that they can be open to them and access services freely. And I discourage them from labeling sex workers, because you never know who a sex worker is. It might be your friend, it might be, your cousin, it might be anyone. In Botswana, we also have non-citizens. I provide services to non-citizens without asking any questions, and I make sure that they feel free, and I also empower them to say, if you did not, you were not happy by the services that you were provided for, you can always ask. There's a nurse in charge, or there's anybody who is higher than the nurse that was servicing you. So you can always ask, and to get another person to report or to voice out what you did not like about the service. And one other thing that I do well is visit sex workers at their homes. I make sure that I do follow-ups, especially sex workers who are on treatment. I make sure that as I follow them up, I make sure to assess other needs. Do you have kids? Are they going to school? So if they are not, then I facilitate to see how those kids can be enrolled in school. So you'll be surprised, because we have sex workers who don't have national identity cards. So if you don't have a national identity card, which is called Omang in Botswana, you can't be enrolled into ART. And I don't blame healthcare workers, because it is in the guidelines that if you don't have a national identity card, you cannot be enrolled. But as you come from the nurse, I asked, did you get the services? Were you happy? They always tell me, I was not enrolled in ART because I don't have any identity card. And I took it upon me that I make sure that sex workers get identity cards. And it is very expensive. It can go up to $200 for one sex worker to get an identity card. And what I've done is to make sure that I write to the district registrar to say, I have vulnerable women. Can you waiver in terms of the $10 that they have to pay for the birth certificate? And then I accompany them to the police. To the police, it's a little bit of a challenge, because there they are charged $50, for late registration of their identity cards. And if I get there and I find an unfriendly police officer, I go back, then I'll come later, then I find a friendly one and I say, can you give a waiver? Can you give a waiver for, for my woman? And they'll always say, where are the parents? And I say, I stand here as a social worker to, to ask. And sometimes we have a challenge here, because you need parents to process these things, and you find that the sex worker has gone for a very long time, and the parents were not happy with that. So you need to mediate and make sure that you bring this family together, and then at the end they'll help you to get the identity card. And to date, I've done 30 identity cards for sex workers and their children, and all those sex workers were enrolled into treatment.
Applaud that.
To add on to that, I don't want to be standing here next year to say, how did I miss them? I don't want to leave anyone behind. So I don't want the question, how did we miss these women? So apart from this, I got trained to dispense emergency ARVs, because our nurses are not always in the clinic. Sex workers are highly mobile. So if they come to our clinic and they find no nurse because they were taken by clients wherever they went, I want to make sure that they get their refills on time, and to make sure that they don't miss any, because they will come at that time because of other reasons that that are beyond them. And to date, I'm proud to say I've retained 90% of 159 sex workers that that we have enrolled into treatment. Apart from that, I trained sex workers as peer educators to engage their peers and disseminate information so that we can increase uptake of services by sex workers. One other thing that I also do in terms of the needs and all that, I make sure that sex workers, they have a health goal, what they want to achieve in terms of their health needs. And I also make sure that what do they need to achieve in life in general. Some want to get married, which is a little bit difficult. Some want businesses. Some want to build houses. And these are some of the projects that we did with sex workers. And they give feedback in our group sections to say, yes, the money that we have saved, this is how far we are. And I never buy eggs from a supermarket nowadays because I have a woman who has chickens, and I buy eggs there. And I remember one doctor, I always sell these services. Others have tents. I sell their services to other providers. I remember one doctor, I said, we sell eggs at our office. And that doctor said, which grade? So I said, why do you need a grade? At the end of the day, you're going to eat some eggs. So you need to. So I make sure that, I take their businesses out there and, they get clients. What needs to be done? I wish these issues, I did not, get to encounter them in practice. I wish this was infused in the curriculum so that nurses, doctors, social workers, pharmacists, they can get everything about key populations from the class, so that when we go into practice, now, we can put sex workers into face. Now we can make sure that we do in-service training, we sensitize people who already know what is happening. And also I wish there could be regular sensitization for different stakeholders about issues that are affecting key populations. And I want healthcare providers to learn, to continuously learn, and you learn with an open mind. If somebody says, I'm a sex worker, you don't have to frown, you have to listen and see how best you can improve your service. And also, I would love government to have a specific strategy that addresses needs of key populations in Botswana. Thank you for your...
Well, Nao, at least one of your goals you already fulfilled, because I just learned something. I learned a lot from that, so thank you very much. I think, when you think about the issue, and we've heard it, Cameron said it, and you'll hear it from everybody, this issue of who gets left behind. People like migrant sex workers living with HIV, right? Triple stigma there. But if they are excluded from antiviral therapy, we will never get control of this epidemic, right? And actually doing that work day to day of getting people enrolled, getting them the ID cards they need, getting their kids into school, that is the work that's going to make a difference. So thank you so much for what you're doing, really. I'm going to turn the co-chair role over now to my colleague, Dr. Manuel Gonçalves. He's the head of External Affairs and Communications for Vive Healthcare. Manuel's a physician by training, an elected member of the Portuguese Medical Academy, and he's on the General Council of Lisbon Public University. So, Manuel, please.
Thank you very much, Chris. It's morning to everybody. It's a pleasure to introduce the next speaker. Next speaker is Dr. Lucia Ank, that works in the Public Health Office of Papua New Guinea. Dr. Lucia is a pharmacist with a very wide experience in supply chain, not only on ARVs, but also on malaria and other drugs. And she has been distinguished with several awards, and I will just highlight that she was considered the best pharmacist from the Indonesian Ministry of Health in 2012. And the title of her presentation shows how difficult is probably a task, because she is going to talk to us about providing stigma-free HIV services to men who have sex. No, I'm sorry, providing stigma-free HIV service to people who inject drugs in Indonesia, a healthcare worker perspective. All of you here in the room may understand how difficult this must be. Thank you very much. Lucia, can you join us?
Okay. Thank you. Good morning, everybody. I'm Lucia. I'm from Indonesia. I'm pharmacist. I'm a head of provincial pharmacy warehouse in Papua. This insurance directs of key population living with HIV to HIV treatment. Here is, as you can see in the slide, show maps of Indonesia and where province Papua. Papua land consists of two provinces, West Papua and Papua. Papua consists of 28 districts and one municipality. It's a capital of Jayapura. Population of Papua, Papua province in about 3 million. It's Papua, its land is beautiful, it's forest and it's beautiful. According to IBBS 2013, estimate HIV prevalence is 2.3% in general population in lowland and highland 3%. Categories is low level generalized epidemic. And according to IBBS 2011, people with injection drug 41% and female sex worker 10%, men sex men 8%. According survey data 2013 in Papua, female sex worker on 13 until 32%. The challenge for key population to access HIV prevention, test, treatment, and care service where they live in resource-poor settings and have this service be free from stigma and discrimination. Example, Josefina. Josefina is not her real name. She diagnosed HIV in 2013 and start treatment in health center. She stopped treatment after 3 months because her being known is HIV positive. There is big issue with lack confidential at health center and community discrimination against HIV positive. Even though there were more to do, no healthcare center offers a stigma-free service which help her get back on treatment. Why Aris nominated me? Aris is a former drug user. He on ARV since 23. He learned that Papua never stock out ARV since he moved in the province. I and my team for ensuring ARV is available and can be accessed by key population and also general population. Before February 2011, distribution ARV in Papua centralized. After February 2011, distribution ARV province to health service. Jadi every month, I and my team distribution ARV to health facility. Before distribute ARV, health facility send report, cash and stock ARV every month on time. Why? I'm using personal approach such as sending reminder, SMS and phone call every month. I send for health facility. And now, distribution ARV every 3 months is a province to district. 4 district, every 3 months, distribution ARV to district. Decentralization ARV increase access for key population and people living with HIV and treatment on. Example, February 2011, people living with HIV in Papua on 976. On February 2017, people living with HIV on ARV 5,556. No puskesmas. Here is my ping. In ensuring and improving the rights of people living with HIV for ARV treatment in Papua, I would like to give my recommendation to fight stigma and discrimination in healthcare setting. I'm sorry. During monitoring and providing assistance at health center, even though my work is mostly papers and numbers, but during my regular health center visit, I discuss with clinic staff about importance of treating clients well so they come back. We don't want any client to suffer like Josephine did because of unfriendly service. Last, in ensuring and improving the right of people living with HIV for ARV treatment, I would like to give my recommendation to fight stigma and discrimination in healthcare center. For government staff, me and my staff, whatever role you have, always talk to colleagues about addressing stigma and discrimination of people living with HIV. I and my staff, every day, I will always talk to colleagues about addressing stigma and discrimination. And I commit, and my team commit distribution ARV on time and no stock out. For patients, be brave. Form a peer group and talk to us about your concern so we can improve our performance. For donors, assist us in design program that will allow feedback system integrate in health facility. Thank you for donors and help us in Papua. For clinic staff, we open mind, listen to feedback and improve our service. Always have high motivation to the best clinic. That's all from me. Thank you for listening.
Thank you very much, Lucia, for a very interesting presentation. And then, as my friend and co-chair Chris was saying, that you're talking about a 5-fold increase in the number of people served. You know, talking about moving from 900 to 5,500 is a huge, huge achievement. So the next speaker is Stella Chigi. I hope I pronounced the name correctly. Stella comes from the Minority Persons Empowerment Program in Kenya. She describes herself as an LGBT advocate, nurse, and counselor, and for the last 2 years she has been involved in leading LGBT and youth advocacy efforts mainly around SDGs. A fundamental goal of her mission is to help build the capacity of the organization she works to meet the social, health, and political needs of the LGBT community members across Kenya. And she will talk to us about providing stigma-free HIV service to men who have sex with men in Kenya and her perspective as an health care worker. Please, Stella.
Hello, good morning, or is it afternoon already? I'm a bit nervous. Okay, as you have heard, my name is Stella Wanjiru Chege. I'm a nurse counselor at MPEG in Kenya. MPEG stands for Mambo Leo Peers Empowerment Group. I'll take you through my perspective in providing stigma-free services to men who have sex with men in Kenya. And that's the outline that we'll take you through. Okay. The HIV prevalence of 18.2 and 11.1 among MSMs in Kenya, that is in Nairobi and Kisumu respectively. The Kenya HIV response and modes of transmission study shows that the MSMs account about 15% new infections. And the MSMs are hesitant to go and access services. This is because they fear being discriminated and stigmatization from the healthcare workers, and this further exposes them to the increase of risk in HIV contracting. Our organization, that is the MPEG, is a MSM-led organization that was established in 2010 and was registered as Mambo Leo Peers Empowerment Group in 2014. It advocates for the human rights, the sexual reproductive health, referral for the security interventions, psychosocial support, and socio-economic support for the MSMs and the LGBT community at large. It started providing the HIV prevention and care services in 2016 through the help and or the support from the PEPFAR USAID funded by the FHI 360 Linkages project. There is a question here. Why key populations should receive stigma-free services? Why? For me, I understand they have the human right to get the stigma-free services, and in order to achieve the 1990 goal. Our organization as MPEG, we have a policy that says MPEG recognizes the impact of stigma and discrimination has on reducing access to HIV prevention, care, and treatment services and the sexual reproductive health. Therefore, MPEG is committed to providing an environment free from prejudice regardless of the tribe, HIV status, age, and sexual orientation of those who are seeking services in our organization. Practices, experiences as a nurse counselor. I saw that there is importance of separating my personal and religious values from professional ethics for the sake of HIV prevention in Kenya. Because if I look at the religious values, I'll never provide stigma-free services to the MSMs because I'll always be judging them. And I also accompany the MSMs to access other services that are not offered in our DICE, such as surgical procedures, that is in case of an MSM that has an OATS. we always take them to other hospitals that we have already sensitized the health workers there. And also, I provide quality health education and counseling to the MSM's patient. It is integral to HIV prevention efforts. It is important to give them quality education so that they can understand the importance of preventing HIV spread. Because if at all they don't understand the reason as to why they should prevent from the HIV spread, we will never get the goal of the 90-90-90. Okay, most of the MSM, they engage in risk behaviors due to poverty and lack of power to negotiate safer sex. And as a nurse counselor, I have come up with a strategy in bringing up them together and planning for or start support group among themselves that will help them maybe start a business rather than doing the risky behaviors. The impact of providing stigma-free services. This helps in the numbers of MSMs accessing services to increase. The HIV treatment among those who have, there is HIV treatment adherence to those who are HIV positive. It also increases, and also there is reduction in the rate of default and to those who lose to follow up. The final thoughts. The key population deserve to receive stigma-free services key population deserve to receive services in a stigma-free environment. As a healthcare provider, we need to be trained in providing these services. Apart from training, they also need to be sensitized so that they cannot judge the MSMs according to how they are. And to all this increases to access to services. And after there is increase in services and the training of the healthcare providers, this helps us to achieve the 90-90-90 goal. Thank you.
Thank you very much, Stella. The next speaker comes from Vietnam, and maybe those of you who were at the opening plenary recognize him because he was awarded in the opening plenary with the Positive Action IAS Innovation Challenge by the work they do with the organization, Lighthouse Social Enterprise, in providing initiatives to reduce stigma and discrimination in Vietnam. So, Dan Tan Tu, please, can you join us?
Hi, everybody. I'm very glad to be here today and see all of you here because I know that we put the same effort to combating stigma and discrimination in healthcare setting. And my name is Đoàn Thanh Tùng and I'm from Lighthouse Social Enterprise in Vietnam. And I am very honored to receive the prize from the View Healthcare and IAS. And I have to say that it's not only a prize, but it's also an opportunity for the community organization to make our innovation come true and put the effort together with the other stakeholders to make our community better. And I want to spend a very limited time of my presentation to call for more invest and empower the community organization in the world to lead and also become one of leaders to end AIDS. And for next, I'm very excited to introduce you about our innovation named Zero to Zero. Zero Stigma, Discrimination and Violence to Zero HIV. This is a joint innovation and a partnership between Lighthouse Social Enterprise and G-Link Vietnam. And my colleague, Lê Minh Thành from G-Link Vietnam also be here today. And we also receive technical assistance from MSMGF as well. So before I go to the detail of our innovation, I want to give you a very brief about the Vietnam context among the MSM and TZ community. HIV new infection among MSM is 7%, while HIV prevalence among MSM is 8.2%, and among TZ is 17%. MSM and TZ people faced with stigma, discrimination, and violence in healthcare setting is based on our assessment in last year we have done with support from MSMGF. And existing project programs do not focus on address stigma and discrimination in healthcare setting in Vietnam. And from that, we also identify the key problems that facing by MSM and TZ community. Firstly, key stakeholders are not aware about severity, stigma and discrimination facing by MSM and TZ community. Stigma and discrimination are a major barrier in accessing health and HIV services. Healthcare providers lack knowledge and information about the community, what is LGBTR, what is SOGI, what is the languages of the community. And the MSM and TZ community lack awareness on self-protection and actively seeking health services, especially HIV services. And finally, the guideline or good practice model are not in place right now to apply for healthcare setting in Vietnam. And in last year, with under Bridging the Gaps project, we also have some pilot activity. We're trying to address stigma and discrimination in healthcare setting. Lighthouse and G-Link work with partnership with MSMGF to firstly, we design and implement an assessment on stigma and discrimination faced by MSM and TZ in healthcare setting. And that is really significant data for us to have idea for this innovation in this year. And we also developed a guideline named Friendly and Supportive Services Delivery for MSM and TZ community. And we also organize a training for trainer for the community member on how to work with healthcare provider and how to connect with healthcare provider in healthcare setting. And I want to go more details on our innovation goals. The first goal is sensitize healthcare provider, local health authority, and relevant stakeholder. We will conduct a survey to collect the idea of key stakeholder and also organize some campaigns to raising their awareness about the community needs and also barrier in accessing the healthcare services. The second goal, we want to sensitize healthcare provider and build a friendly health facility models which can be expanded to the other area and the other country. In this, we have three activities. Firstly, we introduce a complete toolkit to key stakeholder and community. We want to integrate with the other existing projects and programs to combating stigma and discrimination. The second, we also do the pre and post training assessment that will make, for the pre-assessment, we're trying to make a recommendation lead to healthcare center based on their characteristics and their opinions. And we also have post-assessment to make sure that our effort, our innovation will be success or have a result. And we also use the client survey, the healthcare center survey, and simulated patient survey. And then we provide them trainings on what they need on our toolkits as well. And finally, we will establish a network among the healthcare facilities as well as between the healthcare provider and the CBO, because it's very important to link between two sides from the healthcare center and also from the CBO together to more understand and regularly feedback to each other. And the final goals, we will raise awareness of key population on health, self-protection, and actively seeking health services, especially HIV services. And here we will conduct an apps on smartphone where the key population can access and see the general information related with HIV, STI, PrEP, PAPS, and also they can access with lists at the healthcare center where very friendly and also without stigma and discrimination with the community. And with innovation approach, the Zero Stigma Discrimination Violence to Zero HIV innovation had three-pronged approach. Firstly, we train and sensitize healthcare provider and the healthcare center staff. And second, we provide technical assistance to the clinic to achieve meaningful change. And the last one, we implement a social media campaign to raise awareness of MSM and TZ community about stigma and discrimination, healthcare services, health education, and more. And last slide, I want to show you a picture of our community, MSM and TD community in Vietnam. And you can see people are very excited, very funny, and very happy. They smile. And this is a picture of future. We hope that after our innovation with support from VIP Healthcare, we will have an MSM and TD community in Vietnam that is healthy, equal, and full of happy. And if you want to reach me for more questions, you can reach me at the email, the last in the bottom. Thank you so much for kind attention. Thank you.
Thank you very much, Dan Tantoon. Our last speaker comes from Geneva, is Rachel Beckley. She works for WHO, and Rachel is the responsible for the coordination of all HIV prevention and HIV testing services activities for WHO. She focuses on key populations, adolescents and young women, and biomedical prevention, including male medical circumcision and ARV-based prevention, including oral and topical PrEP. Thank you very much, Rachel. Please.
Thank you very much. Thank you very much, IAS, for putting this on the agenda. I think it's really fabulous and incredibly important. So I really want to particularly thank Kevin Osborne, who really, I think, is pushing this agenda forward in the IAS, and Nelly for arranging this session. It's really exciting to be here. I'm just going to give you a little bit of policy background on what we in the UN are doing about stigma and discrimination. And although it's focusing on key populations, I also want to say that healthcare workers who are living with HIV often face problems, and of course people in general living with HIV. And we know, and this has been very eloquently spoken about by Cameron, we know the reasons why we have such low uptake of services for key populations is because often the attitudes and of healthcare workers really don't entice them into settings. And it's fantastic to have these wonderful examples here of really what can be done, and I really want to applaud the examples we've seen. As Cameron mentioned, we developed our key population guidelines in 2014, and Chris Bayer was the chair of our guidelines, which is probably why they're so good. And I think other people in the audience here, I think Coletso was here earlier, again, was part of our team. So we had our clinical guidelines, but absolutely as important were what we called our critical enablers. And we said there's no point in having lovely, fancy recommendations on treatment and prevention and testing without these four pillars, looking at laws and policies that should be addressed to have equitable and safe access, looking at stigma and discrimination, looking at community empowerment, and looking at ways to address violence against key populations. And in these guidelines, we give really good examples of how countries have tried to address some of these key pillars. And what I feel really proud of the HIV community, working in WHO, obviously we're the World Health Organization, and although we all think HIV is the most important health issue, there are many others that the World Health Organization deals with. And in June, just a month ago, the UN released a statement on ending discrimination in healthcare settings. And this was across the board. And I think HIV, if we hadn't had the HIV community driving these discussions, we would not be where we are today with this amazing statement that really is across all health, for all health conditions. And it was the last thing that my old boss, Dr. Margaret Chan, did before she left. I think it really was close to her heart, and she really wanted to do this before she left. And it was fantastic to have my new boss, Dr. Tedros, there with Michel Sidibe to launch this. And I'll go through it very, very briefly. There are 4 main areas, but I urge you to look at it in detail and make sure that everyone is aware. This is what the UN is saying, that we really must review and strengthen laws to prohibit discrimination in provision of healthcare services. And I want to single out here, for the second part here, review and repeal punitive laws, and those include criminalisation or those that criminalise or prohibit gender expression and same-sex conduct and any other sexual behaviour between consenting adults. This is what the UN is saying. I think this is really great. We also want to review and repeal laws that prohibit adult consensual sex work, the drug use or possession of drug use for personal use, and criminalise non-disclosure, exposure or transmission. These are very powerful statements that we are saying in this. We also, the second area is empowering health workers to realise their own rights and have a safe environment in which to practice. Very, very important, and I think it's great to have good policies and bold policies, but accountability is absolutely key. And to have mechanisms of redress and accountability are so important if we're actually going to move on. And again, wanted to dwell on what Cameron said about the examples that he's supporting, so that bad services don't continue. And I think really this is a huge thing that should be in all countries. So finally, really, what do? We have this great policy. We have our great guidelines on key populations with those 4 bold pillars. And how do we move to action? And I just wanted to highlight a few examples of really great things that are happening. And I think the 4 main areas for me are ensuring that key populations and adults with HIV are part of the team, really there from the beginning. They're there, and healthcare workers, health services, health policymakers must listen to them. Understand their concerns, involve them in monitoring of the stigma and discrimination within their community healthcare settings. We must really try and support healthcare worker training and make sure that this great practice that we're seeing is much more widespread. And I really want to call out here a colleague of mine from the Eastern Mediterranean and North Africa region, Jemana, who has led in that region, a very difficult region to work in, their work on having a charter for healthcare workers, and dignity above all is their slogan, and they also have healthcare worker training, and there are many programs like that. And I was there was a conversation about stigma and discrimination in healthcare setting yesterday, which Kevin Osborne arranged, and it was a lot of back and forth between the communities and the healthcare workers, and saying that training is not great. It doesn't really. And I think we've got to make this a journey. I think one-off trainings are not going to work. I think healthcare workers do want to give good services, but they need support and continued assessment and feedback from the communities when they're doing well and when they're not doing well. And we have a UN policy, but we need to develop national and site-level policies to prevent stigma and discrimination. And reviewing laws and policies that criminalise key populations are difficult, but we have some champions. And one of the very unlikely champions, well, probably shouldn't say unlikely, but it's great to have a champion in Zimbabwe, which in 2015 made the arrest of suspected sex workers for loitering illegal. And that's a great step to really, the first step to accepting that sex work shouldn't be criminalised, and keeping, arresting sex workers and putting them in jail is not beneficial to anyone. And I think even in difficult settings, looking at the public health aspects of some of these punitive laws is something that can be done and should be done as a joint thing between Ministries of Health and Ministries of Justice. Finally, I just want to say that our UN statement has been a joint statement between WHO and UNAIDS, since it's been launched, many of the other UN agencies have also signed up to that, so that's incredibly powerful. I also want to thank my colleagues, and particularly Hallie from Linkages. We have a great partnership with Linkages at WHO, and we really applaud their work. And finally, I really want to thank my panel, who are so much more eloquent than I am and doing this fantastic work on the ground.
Thank you very much, Rachel. Before passing the microphone to Chris, who is going to moderate the questions and answers, I'd like to share a thought with you that may even steer the discussion. There are things that differentiate myself and Chris. We have many things in common. The most obvious that differentiates us is handsome and tall. I'm not tall. But the thing we have in common that probably we've seen, we are both members of the medical academies of our countries. And we dedicated most of our life to healthcare. So it's quite shocking that we have to discuss a subject like stigma and discrimination in healthcare. We, as healthcare practitioners, the ones in this room, we have the obligation of creating a safe environment for key populations in the places where we work. It's quite unacceptable that we have to come here and discuss that. This is almost as basic as the basic thing that we as medics have, that is a basic thing, primo non nocere. We have this, so it's almost shocking. And the people, the key populations have all the right to demand, to oblige healthcare providers to create that. This is not something, this is a basic human right. And it's a basic obligation for healthcare providers. So, Chris, the handsome guy and tall.
Well, well said, well said. Not the handsome tall part, but the part about being a fundamental right. One thing I think it's important to say is that a number of the people on the panel, of course, were awardees of this Me and My Healthcare Provider campaign. And the way this works is that providers are nominated by the clients they serve. And we're really honored today to have two of those clients who nominated here with us. So Neo and Louisa's nominators are sitting in the front row with us. Aries, maybe you just want to stand and be acknowledged. Thank you for that nomination. And Chedza, who is here, who nominated Neo. So welcome. And with that, we have about 15 minutes for a question and discussion. I see there are several people at the mics. Please keep your questions short. Tell us who you are, and also if your question is aimed at anyone in particular, let us know. Please.
Yeah, David Barstow from Impact Africa. It struck me that only one person on the panel mentioned religion, and that was religion as a barrier that Stella mentioned. And it seems to me it's an important avenue for us to mobilize religious leaders and faith communities to work against stigma and discrimination rather than seeing them only as barriers. So if anybody on the panel would care to address that, I'd appreciate it.
Anybody? Stella? Well, let me just say that I totally concur with that, and have been blessed and very fortunate to work on some of those issues with Archbishop Desmond Tutu, who of course is a paragon of exactly that, of inclusion, always making the point that nobody is outside his father's tent, as he likes to say, and I think that's absolutely right. I'll just say that today there was a very important opinion piece, some of you may be interested, from Rick and Kay Warren, who are faith leaders in the United States, on the importance of continued funding for PEPFAR, and that was very much aimed at Congress and at the Trump administration, and a great example of faith leaders and making it, yeah, indeed.
Oh, Chris.
Yeah.
Sorry, I thought we were taking more questions, so I
Okay.
didn't put my hand up to say something. But yeah, absolutely. I mean, it's so important to recognize that, you know, so many services, particularly in the African continent, are provided by the faith community. They have a massive role to play, and indeed, faith leaders can play a huge role in shifting attitudes. As Chris mentioned, I was at UNAIDS for many years, and within my team, we managed relationships with the faith community, and I just would like to acknowledge the work that particularly UNAIDS and the UN family have done around this. I think as Global Fund, we, you know, when we talk about country-level stakeholders, clearly we can't talk about country-level stakeholders without acknowledging and engaging with faith leaders who can sometimes be barriers, but, you know, more often than not can play a real role, particularly, I think, if you take the time to actually like work with them and build their understanding where it doesn't exist as well.
Thank you, Chair. I'm Dr. Namis Charles. I'm from Uganda, and I'm working on my PhD topic is stigma. I'm trying to empower people in stigma in HIV, empowering people living with HIV in stigma management. So I've been listening. One, it seems we are misinterpreting the definition of stigma. Discrimination is a form of stigma. It's the enacted stigma. So when I hear people saying stigma and discrimination, I start wondering. So the first question, I'm not asking anybody, but I thought us should reflect. Do we really understand what is stigma, how it occurs, and why? To give a story of Yosin, is it Yosfina? She refused treatment for 3 months. What does that statement mean? That whatever was within her was able to tell her, no, you better die, but not go for medicine. Now, do we understand the context, therefore? So when I see or hear you talking of stigma, I start thinking you are scratching the surface. Rachel talks of the policy. You see, all those people presented extremely good work, but it's not theory-based, but it's working. So then the good policy will be the one which explains practice. I hope you appreciate the difference, because we do policies based in offices that are not practical. But we don't want to formalize what's working and try to see how we make it a policy. So what we lack is then the positive component. How are those people who have survived? Those who are stigma-free? What is it that's unique within them that makes them resist us as MSMs, as sex workers? That's what's missing. We keep talking of sex work as if the sex workers are pushed. You will be totally surprised that there are people who go into sex work and that's their dream, like you dreamt to go and do a STEM course, be a professional. And for them, that is their main thing. They have nothing else to do, that they just want to do sex work. And there are a lot of gains in sex work, that what she does in a night or in a week pays much, much higher than what her counterparts.
I'm going to have to ask you to wrap up.
So that's where I've ended. So I was thinking, let us put the context, the individual perspective. Let us use the lens of the MSM, the lens of the sex worker. Let us not use the lens of the police worker. Thank you.
Okay, thank you for your comment. Please.
Hi, thank you very much for a wonderful panel. Carrie Johnson from the U.S. This question is directed to the providers and potentially to the client nominees as well. We know about policy, and we know about the trainings and how those are important elements to getting stigma-free care. But I'm just curious, I also think it's a question of maybe changing hearts and minds. And I think your examples of how your hearts and your minds have been changed such that you can deliver this care. And I was just wondering if you had thoughts about how that secret ingredient of changing hearts and minds, what's that component? What would you say would be some key recommendations to changing the hearts and minds of your potential allies into advocates, allies, and activists? Thank you.
For me, it took a story from a sex worker. She told her story, and I listened, and I knew that I needed to do something about it. I needed to provide services that are relevant. That sex worker was calling for Ministry of Health to give them STI screening because they were afraid to go to clinics. They wanted to particularly go to the STI clinic as sex workers. So it took a story from a sex worker for me.
You want to comment as well? Just see you leaning forward. No? Okay. Well, there's nothing like really hearing somebody's story from the heart, to start to change our thinking. Please.
Hello, I'm Carrie. I'm from Brazil. I'm a cisgender gay man, live with HIV, and I'm a medical doctor. And my question is about changing minds of healthcare workers on specifically on LGBT issues. I know training is important, but sometimes it's difficult to change individuals' mind, while the national authorities on knowledge, the professional associations, still keep being very cis heteronormative. In Brazil, while psychology and social workers, professional associations have long been discussing LGBT issues, the medical professional associations are very heteronormative and sometimes very homophobic, where, how it's expressed on textbooks, on conference, on guidelines. So my question is about engaging these stakeholders, the projects of WHO, Global Fund, the linkages that these stakeholders are being there are plans to engage them. I know it's difficult to face the national authorities of knowledge, but what's going on about that?
Rachel, I don't know if you want to comment on that or
Well, I do think actually there's a common theme for some of these questions. It's about stories. And I think if we're going to change hearts and minds wherever they are, right, in the ministry, in the professional associations, it's involving people from communities at absolutely every stage. I mean, from a personal level, I started my work on HIV, working with drug users in South London, and I became so thrilled with working with drug users because they're, you know, exciting, interesting, fun people, and the same with sex workers. People are people, but you've got to have that day-to-day experience, and I think that is so important. So I think involving the LGBT community directly in changing the mindset of people who are making these, making decisions, making policies, in medical school training, in nurse training, in refresher training. None of this should be done by by boring people like professional trainers. It should be done by the communities.
Let me just add, I'll take the chair's prerogative for a moment, that in the U.S., the critical issue in terms of advancing LGBT health and legitimizing LGBT health research such that it's fundable through our national funding agency for health, which is the National Institutes of Health, was an Institute of Medicine, an IOM report, 2011, now our National Academy of Medicine, that defined LGBT health as an area of health disparities research. And that really was very important, and it was definitely led by a group of LGBT physicians, providers, and scholars. The late Judy Bradford, lesbian health researcher at Harvard, played a critical role. And so for others thinking about how to advance that in your country, getting the national academies on board with this work is really very essential. Whatever the normative body is, that makes a big difference. I'll just also share with you personally that, as an out gay man in this field, I never realized until somebody mentioned it to me that after 25 years I was the first openly gay leader of the International AIDS Society, and that seemed kind of ridiculous, And the first time I said it, I just said it as a kind of as an aside, and an audience erupted in a roar, and I thought, people don't do this enough. We are not honest enough about who we are, right? And
Yeah.
that's important too. You just have to do that. Please.
Thank you so much. My name is Antula Simwinga. I'm under Positive Vibes from Zambia. And I have a question and a comment. And part of my comment is that I think I wish to applaud my two sisters from Botswana and Kenya. There is what we call stigma by association, where I come from. People must understand that the laws and also the religions we have, when you're talking about laws, the penal codes and everything, were practically brought in by our colonial masters. And these are the issues we're still struggling with, both the religion and also the law. So if you look at the penal code, which is there in Kenya, it's very much a copy and paste of what we have in Zambia. So we're still struggling. And these are the platforms where the police and other healthcare workers ride on to fuel stigma and discrimination. So if these are not addressed with a public health lens, then we are still struggling. So I just have a question for my sister Chege. There is this which, when you go to the office, because I've been working as a clinician for the LGBTI community for the past 10 years, both in the public and also private sector. And when you go back to work, you find an LGBTI person or a K-pop waiting for you. The nurse colleague of yours or clinician colleague will say, your people are here. They are still waiting. So how are you trying to infuse the teamwork spirit within your workspaces so that it doesn't just need to be your people, you alone? And also one other thing is the risk, because you're put on the microscope, I believe, even when you're out of the workspace, even when you go to church, they will know that you still have your people who you work with. How do you handle that? Thank you.
Thank you, my brother. Okay, for me, I think sensitization is the most important thing to everyone. These are my people. I won't deny that. And they need me. And to the other people, maybe to the churches, I need to show them these are like any other human being, and they have the right to access services. Yeah.
Well, I'm afraid we're out of time. I'll ask you, if you would, whatever your question is, to please bring it up to the panel, and then just also to ask all of you to join me in thanking this spectacular group of speakers.